That was fantastic. Thank you so much, Dr. Da Silva. I'm going to ask you to stay here on the stage. We're going to have a short panel discussion. Our panelist for this discussion is Dr. Brian Goldstein, our director of the Cath Lab, Dr. Chris Craig from Memphis, who is the director of the surgical program at La Bonheur Children's Hospital, Dr. Da Silva, Dr. Mario Castro, one of our wonderful surgeons, and Dr. Norm Silverman from Stanford. So please join us on the stage. Thank you. And as we start, I have a question to Dr. Da Silva. So when you're augmenting the septal leaflet, what kind of material do you use to augment the leaflets of the tricuspid valve in Epstein's patients?
Well, to augment the septal leaflet, some surgeon has suggested to augment also the anterior leaflet. I think usually it's big enough, so if we mobilize well, we don't need to augment the anterior leaflet. But regarding the septal leaflet, if the patient is adult, I prefer to treat the leaflet with growth hormone, but it's always autologous pericardium. And in small patients, in children, I prefer to use a fresh homologous pericardial patch. But by now, we don't know for sure which is the best option. It is something that we have to study. We do in about 10% of our patients, so very soon we're going to have enough patients to study what's the best patch. I don't know for sure. Thank you.
Dr. Craig, do you have a comment on that as well?
No, I agree with Dr. Da Silva. I think autologous pericardium has been what I've used.
Fantastic. A question for Dr. Goldstein. I know we use cardiac catheterization in many of our patients before the cone operation or in patients with stars before we convert them to a cone operation. Are there any cath biomarkers that will kind of sway you away from doing a biventricular conversion in these patients?
Tarek, thanks for the question. Man, I'm not the right person to answer this question. In some ways, I look at this as a partnership. In this particular partnership, our job is to get high quality, reproducible data that allows our team to make good decisions in terms of biomarkers that facilitate that decision as to what's good and what's not. Our impression is seeing a good right ventricle that squeezes well, generates some kind of pressure, and has good pulmonary arteries with pulmonary vasculature, meaning low pulmonary vascular resistance, going to facilitate easy antegrade flow, is all sort of positive in my mind. But ultimately, I would say this is a decision that's not made by our team. Our job is to acquire high quality data set.
Fantastic, thank you. It's kind of like a team decision rather than just a cath decision.
Yeah, I mean, like anything in a congenital heart center, it's really a team-based care. So I agree with that statement.
Great. Fantastic. Thank you. Question for Dr. Silverman. You showed very nicely, Dr. Silverman, that there is sometimes fusion between the septal and the inferior leaflet, almost creating a bicuspid, tricuspid valve. How often do you see that, or how often do you can you always differentiate between the septal and inferior leaflet, or are they sometimes kind of become only one structure rather than two structures?
Right, it can be sheet-like. And it's impossible to recognize it because there are no commissures to guide you. The only thing you have to guide you are the papillary muscles. And the one example I showed this morning, there were two groups of papillary muscles on the posterior leaflet with a commissure or a cleft between the two. So it can be very complicated and very difficult because you don't have landmarks to recognize a commissure.
Mm-hmm. Fantastic, thank you.
We showed anterior and septal, but you can also get septal and posterior leaflet fusion. I'm sure Dr. Da Silva can tell you that you've seen more of them than I have just seen on the echocardiograms.
Yeah. Dr. Da Silva, and you want to comment on that?
Thanks, it's very significant. You're asking very important questions, but we don't always know the answer. In this case, sometimes the anterior and septal leaflet, they are in continuity, and you don't know where one finishes and the other starts. But for us, in that situation, to have a lot of linear attachment and to have a single hole going toward the outflow tract of the right ventricle, it's important to take down those attachments so you can mobilize the valve to the center, of the right, to the body of the right ventricle. That is very important. And it's especially difficult to define where's the inferior leaflet and the septal leaflet, the limit between them. And when you have a rotation of severe rotation, more often you don't see the limit there. So I think they are fused and you cannot recognize except for the positioning. So you don't have the precise limited, but you know how do you say, both together. You see a single piece, the part is the anterior part is the inferior. And you have to define the apex. You have to save some connection, distal connection with the apex that you don't touch. So you kind of transfer the apex of the valve to that region.
Fantastic. Thank you very much. A question for Dr. Castro. I know, Dr. Castro, you do a lot of the Starnes operation for patients with Epstein's in some sick newborns. So in a sick newborn, would you rather do put the kid on ECMO first, let them recover a little bit, and then do the Starnes operation? Or would you rather take them to the operating room and do the Starnes right away?
So usually our experience here, only the sick kids that, like for example, the kid we have a circular shunt, that kid we did not go on ECMO right away, we just go to the OR and did the Starnes, and that's the one that Dr. Da Silva later did the Starnes after the cone. And the other ones, they're coming pretty sick, so basically we stabilize on the ECMO the first few, they come in the first hours after being born, we've been putting on ECMO, and then the Starnes procedure is usually, the day after or 2 days when they're more stable on ECMO. So that's basically our scenario. The other ones that, the newborns that, they already discussed that case that, they evaluated and just decided to put a PDA stent, let it grow, and probably later make the decision if we're gonna do something or, or get the Starnes before the Glenn, or maybe just do the Glenn Starnes and then the cone when they come for the Fontan. But basically that's our motto. If the kid is so sick, we go on ECMO and then the Starnes, circular shunt, we do the Starnes. And those are the scenarios we've been having here. Now we have a supply of newborns that is McGee. That's basically our supply for newborns here at Pittsburgh. So we got a few Starnes, in the last few years. I don't know, Jose, you have any other comment?
I think I agree with what you said. I just want to remember that when you have circular shunt, you have to stop the flow in the pulmonary artery, because otherwise you're going to have a circular shunt. So you do the Starnes and interrupt the pulmonary artery. And then you have to use a method that you don't destroy the pulmonary valve, if possible. And mostly you can either suture patch inside the pulmonary valve artery, or you can put some tape around the pulmonary artery. That will be easy to remove after when you do the conversion to cone repair.
Dr. Craig, the same question for you. If you have a sick newborn, would you rather put them on ECMO before you do the neonatal repair, or would you rather take them to the OR and do the neonatal repair?
Well, 25 years ago, I would put them on ECMO and then do the repair. None of those kids survived. So currently, if we have a patient with a severe circular shunt, We would ligate the main pulmonary artery, place pulmonary artery bands to avoid overcirculation, give them a day or two to recover, and then take them to the operating room. And at that point, you have a look at the right ventricle and tricuspid valve. Often they're suitable for a biventricular repair. If not, you do a stance, and if they are, you unligate the main pulmonary artery, ligate the ductus, and do a repair. The advantage of that management strategy is, again, in my experience, the patient with severe circular shunt are really sick. They're in the neonatal intensive care unit. There's people running around trying to put UACs and UVCs in and get inotropes going. And it takes 3 or 4 hours to get the OR set up and get the bypass machine set up. And all of that, you can do a main pulmonary artery ligation and pulmonary artery bands at the bedside in 35, 40 minutes. And that usually changes the lactate from 11 to 4, and then you've got 24, 36 hours to take the patient to the operating room and more definitively palliate them.
That's fantastic. Thank you very much. Yeah, go ahead, Dr. De Silva.
I think that the other possibility is to do the delivers side by side. And then we have done this, we have described this too. In Brazil, we did one. Actually, I didn't do, my colleague there did it. He put the patient side by side and then was following the echo and the blood gases. Everything was going, the tendency to go to worse. Then he opened the chest immediately. So this will take very few minutes because everything was prepared beforehand. So that's another strategy that can be used to resolve the issue of low cardiac output quicker.
That's great. Thank you very much. Now let's say he's a little bit less sick. So the kid is like a newborn, desaturated, and we're trying to decide if we do like a PDA stent or if we do the Starnes operation. So I want to go back to Dr. Goldstein and ask, what's the role of putting a PDA stent in some of these quasi-stable Epstein patients, newborns?
Yep, thanks, Tark. PDA stent is certainly a really nice adjunctive therapy in patients who are desaturated, where circular shunt is not on the table as an issue. It really is establishing a stable source of pulmonary blood flow for an interstage period of time before something next. And so, again, in the team spirit, I think this works out very well as a strategy to leave a virgin chest for that next operation, but establish a stable source of pulmonary blood flow that's reliable, allows the pulmonary artery vasculature to grow, and then move on to what's coming next. But clearly, in this scenario of severe tricuspid insufficiency, pulmonary valve, incompetence, et cetera, this is not a great strategy. But in the setting of pulmonary atresia, functional pulmonary atresia, where the size of the heart and compression on the airway, et cetera, is not an issue, I do think PDA stents are a really nice, 2024 approach to establishing a stable source of pulmonary blood flow and leaving the chest closed.
Fantastic. Thank you very much. Any comments from our surgical panel on that particular question?
So I appreciate all our interventional cardiologists' activities. I have a personal bias against a ductal stent in the context of Epstein's anomaly, and the reason for that is the ductus is directed directly at the pulmonary valve, and so it limits a marginal right ventricle from ejecting into the pulmonary artery because the flow is directed directly at that pulmonary valve. So my bias would be either to do a biventricular repair and ligate the ductus, or if you don't want to do a repair, do a more peripheral shunt where the flow of the shunt is not directed at the pulmonary valve.
Super interesting for sure. That is where the duct is directed. The first step for us was to make sure that when we do this stent, we don't trash the pulmonary valve. And I think we've been able to do that well. But from a velocity of blood and kinetic energy of blood, it is hitting it head on. I would love to see MR data to suggest that that approach actually plays out as a functional difference in terms of antegrade blood flow, because I think hypothetically it's really interesting. An MR probably could give us some sense of whether or not that worked if you had a couple of patients down both pathways. It is a very intriguing thought. Thanks.
Thank you. That is great. I think we have time for one more question to the panel. I'm going to ask this question to Dr. Da Silva and Dr. Craig. If you have a stable Epstein's patient with severe tricuspid regurgitation and gradual dilation of the right ventricle, who's starting to get symptomatic, what would be the best age you would, like if you have to decide the best age to do the tricuspid valve repair or the cone operation, what would be your, your chosen age to do the operation?
3 months. At 3 months of age, you can do a Glenn safely, and the Glenn is God's way of saving the cardiac surgeon from disaster. Because you add a Glenn, you've got cardiac output, and then you can do a quasi-good repair.
Yes, I think the patient that is stable and the patient has cyanosis, then I agree that we have to do early. I don't know if it's 3 months or 6 months, but it has to be early on because the cyanosis is not good in the long term, can deteriorate the ventricle, and also the patient, is not well oxygenated, not very good. And after 3 months to 6 months, we can do the operation with good result, and that one could be the reason. But if the patient is not cyanotic, then we can wait a little more, or it's not severely cyanotic, it can be cyanotic, but with the 80 or 85 or so, or 90, then we can wait a little more and do around a year of age, a little before or a little. This has been our preference, but we need to have more studies to see what was the best. But I strongly agree that you do have to do early on if you have cyanosis, especially severe cyanosis.
That is fantastic. Dr. Craig, you have a
One
comment?
last comment. So I've had 3 referrals from Oregon, all 3 of them from Oregon. And these were kids that were neonates, severely symptomatic, and somehow staggered off ventilation. And the cardiologists would call and say, the patients are fine, I think we can wait. And the symptoms of the patients, all 3 of those patients died, and they died of aspiration. The diagnosis was aspiration. I think severe right heart failure in the neonate and the early infant manifests itself in feeding intolerance, and that's the genesis. You'll hear all 3 of these cases, the patient died of sepsis secondary to aspiration, and I think what they died of was right heart failure without an adequate intervention, surgical intervention.
That's fantastic. That speaks to the role of trying to do early referral, especially when there is excellent surgical experience. That is wonderful. So thank you guys so much for this wonderful discussion. Please give our speakers a round of applause.